Welcome in everyone to the White Dress Project's first of 2 webinars in collaboration with Healthy Women this afternoon. We will be talking with an amazing panel of doctors and patient advocates about health inequities and implicit bias in the treatment of uterine fibroids. We will also discuss the role that doctors and patients play in addressing these issues and how we can partner together for the healthcare that we all deserve. This is a safe space, we like to say. And so this is a conversation. We want to educate, impact, and empower you at the end of this hour. And so we encourage all of you, if you have questions, to drop them in the chat. We'll try to get to as many questions as we can. But we really want this to be a conversation, and we want you to walk away feeling like you have the tools to fight for the healthcare that you deserve. So let's just dive right in. I want to start with the panelists really introducing themselves, because I can't do your bios any justice, because we have amazing women who are here, doctors and patient advocates. So let's start with front and center with Dr. Linda Bradley.
Thank you. And I'm very happy to be here today. I'm Dr. Linda Bradley. I am an OB-GYN, but no longer deliver babies. And I'm at the Cleveland Clinic in Cleveland, Ohio. And over the past few decades, have really begun to dedicate my interest, research, advocacy, attention, and seeing patients in my practice who are looking for alternatives to hysterectomy, evaluation of abnormal bleeding. I have a special interest in a certain type of ultrasound that may be of benefit to some women for evaluating their uterine fibroids. And I also am very involved with operative hysteroscopy, diagnostic hysteroscopy, but also work at the Cleveland Clinic, and I'm director for the Center for Menstrual Disorders and Fibroids. And while I may not do all the surgeries within our division, it is a multidisciplinary division that looks at women, and we believe in the we. We are a team. No one doctor knows everything. I can explain later about our multidisciplinary team working with radiologists. They are our friends and not our foe. There's no competition. I also work at an academic institution where we work with fellows, residents, and medical students. And they are also a part of our team because they also help us with some of the research and things that we're doing. So I do believe that women deserve the right to get second, third, fourth opinions for fibroids, fibroid-related symptoms. Sometimes a surgical knife is needed, but sometimes medical therapy is needed. Sometimes a tincture of time is needed. So we try to look at the entire patient. And I've often said that a woman, we are more than the sum of our body parts. So we have to look at what each woman brings to that table for what she's looking for, and be able to be sensitive with being great listeners, have the skill set to evaluate and treat, and then work together to get the solution as close to what the patient needs. And I do look at fibroids, and I've said this a lot in my writing, that fibroids are unique and one of a kind. I'm from Cleveland. We get snowflakes. Each snowflake is different. We'll have it in 2 months probably. And your thumbprint, fingerprints. Even if you use clear for your eyes, everyone's eyes are different. Their fingerprints, thumbprints, a snowflake is different, just like a fibroid. So when patients are speaking about fibroids, make sure that you're telling your story, that your doctor is evaluating your symptoms. And finally, what I would say is, having been at the Cleveland Clinic for decades, I'll get referrals from patients. Oh, I want you to do what you did for me for my sister or my cousin or my friend. And I have to say I can't, because I need to see your sister, your cousin, or your friend, because everyone's treatment will be very different, just like a thumbprint or a snowflake. So I'm happy to be a part of this. The word doctor in Latin means teacher. And what I try to do in my domains of my office is to really educate women, inform them, and make sure that they look at the potential options. Not every fibroid option is for every patient. So size, number, location, fertility desires, just lots of critical conversations that we have to get to where a patient needs to be. But I'm happy to be a part of this panel. I'm happy to have chosen obstetrics and gynecology and have moved into gynecology only, because there's a lot of work that we need to do and a lot for women's healthcare. So I'm glad to be a part of your team today. Thank you.
Thank you, Dr. Bradley. And let's pivot over to your partner, another teacher, Dr. Somi Javaid. You would, before we started this panel, you actually connected a bit because you have mutual pasts and histories. Talk about where you started, where you are now, and the work that you have done in this space and with the White Dress Project.
Yes, we're both Clevelanders. So I'm Dr. Somi Javaid. I'm a board certified OB-GYN as well. I have been in clinical practice for 20 years now. I started a center called HerMD about 7 years ago in Cincinnati, Ohio, because there is such a gender bias in medicine. Women are currently underrepresented in every single clinical trial. We are not receiving enough funding dollars for research. There are not enough female decision makers. And there is still inherent provider bias. And all of this combined is leading to up to an 8.5-year delay in diagnosis of female conditions like endometriosis and fibroids. And so our goal is at HerMD for empowerment, education, and advocacy. We have 2 centers currently, one in Ohio and one in Kentucky, and we have 4 under development. We've had women travel to us from 37 states because we also believe in listening to our patients and truly empowering them and becoming partners in their healthcare rather than just telling them what they need to do. We are also dedicated to performing clinical research because I believe that is a key facet on how we are going to narrow this gender gap that exists currently in our country and in our healthcare system. And so that is what HerMD is about.
Great, thank you so much. Now let's pivot over quickly to our patient advocates before we can really get into our conversation. Lana Douglas has joined us.
I'm a women's advocate, also model and motivational speaker. I share my story of dealing with infertility for over 17 years, also being born with a double uterus, a double cervix, and then finally being diagnosed with fibroids, endometriosis, PCOS, and just the battles of not being properly diagnosed, not being listened to, my pain being, minimized. And I had to speak up for myself. I had to learn that if I don't speak up for myself, that my body will not be taken care of. It's my body, it's my voice. So I use every opportunity that I can to share my story, to help others to know that they should advocate for themselves, and it's not over. There's still hope.
Wonderful, thank you so much. I'm going to pivot over to Nikki Mayo and then Nicole Jones. If you can just introduce yourselves, ladies, real quickly before we get into our discussion today.
Hello, everybody. I'm Nikki Mayo. I'm a multimedia journalist, and I've been in this game for about 2 decades at this point. And I came to the White Dress Project through my advocacy. Frankly, they hired me first, and then I got to have a front row seat to all the dialogues with the doctors, to all the testimonials, to all the latest treatments. And after a while, I started wondering, what's going on with my body and my life? So the information is definitely out there. I just wanted to make sure I got that out there before we got to all the doctors here. But the information is out there. I was just peeking at our Facebook page alone. And if you just go under videos alone, and it's not me advocating my work, but more so, you're going to find something in there that speaks to your situation. If you are joining us looking for a guide, an opportunity. Now, full disclosure, I am the daughter of a nurse who worked at Johns Hopkins forever. So I've always had a front row seat to everything from research to, things you should be paying attention to. And as a journalist, I've always wanted to help people realize that the folks in our stories are not that far different from you. So I'm here more so because I've been using my platform ever since I started working with the White Dress Project. I got a myomectomy last year by Dr. Jackson, who was also honored with a Blossom Award earlier this year. And I've been feeling amazing ever since. So I was a person who I felt something wasn't right. I want that partner that we talk about all the time in my healthcare. And I started asking the right questions. So hopefully after this conversation, anyone watching will also feel empowered to ask those questions.
Hello, everyone. I'm Nicole Jones. I am a patient advocate. I have joined forces with the White Dress Project. It's been such an amazing journey of learning my own body. Some people know me for actually having a 27 centimeter pushing 28 centimeter during pregnancy. And I had a fibroid that kept growing during the pregnancy, which I had no idea at the time that was even possible. But in quick research, thanks to the White Dress Project, I was able to really not only be in a calmer state to make sure to see my pregnancy through, but staying hopeful and understanding that I was able to carry my child when all, what they would consider all odds was against us, but having the understanding what information is out there, and then having to make the choice between a hysterectomy versus an open myomectomy, which I was able to do, which was very risky, but that was, understanding what my options was. Here we are today. My baby's here. So it's been a great journey of actually understanding what our bodies are capable of doing. And honestly, I feel like here I am. There's been a long list of women, especially my mother, in my family, not actually having the resources and there wasn't able to advocate for themselves. So it's been an honor to actually be that pillar in my own family to advocate and to understand what's going on with our bodies.
Yes, thank you so much. And congratulations on your success story, your love story, and really advocating and fighting for your health. So let's dive right in. And I want to go to you, Dr. Bradley, first, because you talked about how, we don't know everything. Doctors don't know it all. So could you go back and just define what implicit bias is and how you've been able to kind of combat that within your practice? How have you seen that kind of play out? And what collaboration do you do with other doctors to try to combat it?
Well, I think as it comes to our bodies and ourselves, in the space of gynecology and fibroids, I think women, Black women and brown women, often other people, in terms of the biases, may see our sexuality differently, our desire for reproductive freedoms, our reproduction in general, very differently. And others may say, why bother with saving a uterus? It's just a woman of color. And these are things that we hear, that we see, maybe it's unspoken. So to me, implicit bias is just sometimes looking, I think we've taken those exams where you, or tests where a picture is shown and what do you think about that person within a second. So sometimes I think that happens in healthcare. In fact, we know that it happens a lot. So the question being like, what do we do about it? I think you call it out when you see it. My role as an educator and as a teacher is also to teach by example and to role model and to bring up in discussions why a statement may have been said, that question, tell me more. A person said this, tell me why would you say that? What was the meaning behind that? So I think, I'm not sure if I'm answering the question, but the idea is, as our speakers and advocates have noted, people may think differently about their age, their education, where they live, what they look like, in terms of who may get certain privileges for uterine preservation. And I think it's important that programs like this educate women. And I see many women and have operated on women close to 40 or 50, 45, 50, 55 who have fibroids, but even though they're not going to have kids, do not want their uterus removed. So the bias can be a bias towards you don't need it, a bias towards, like I said, reproduction, a bias about, it doesn't matter. It's just very common. And I think it's important for us to disconnect some of these biases by what women want. And I think, I'll leave it right there because I don't want to say everything right now, but the idea is to be aware that there are really many biases towards, and actually it's for many women, towards hysterectomy right off the bat for the treatment of fibroids. And if you go to Europe, you go to Canada, you go to other countries, It's less frequently done. And I don't think it's because of lack of care, but I think we look at fibroids and treatment is very different. I don't have a lot of jokes, but I often say, like, what do you call a woman in Cleveland that has a uterus? She's a tourist. Because you have, especially if you're in like a place like New York, where it's very lots of travelers and things like that. So you go to the South, you know, the Mississippi appendectomy, or Alabama, you know, every other woman gets her uterus removed for little to no reason. So we have the skill sets, we have medicines now, and the bias towards removing the uterus, I think, should be dismantled. It's the best word that I can say.
Yeah, I agree. We have a comment from someone who's joining us, Rachna, who says 100%, so crazy how much pressure I receive to have a hysterectomy from a woman GYN. And so, Dr. Javaid, you know, you talked about how women often are not even included in the clinical trials. There isn't enough research. We hear so many folks and so many Black women specifically, although we know that fibroids affect 70 to 80% of all women by the time we're 50. So this just isn't primarily an issue affecting Black women disproportionately so, but we're all impacted. But I hear a lot of Black women say, doctors don't take our pain seriously. So what do you suggest a patient do in that situation? So I guess a two-part question. One, how do you combat it yourself within the industry? And two, what are your recommendations for patients when they hear that kind of coded language from a doctor who's really angling towards a hysterectomy?
So I always tell my patients, no one knows their body better than they do, because they're checking in with it every single day. So if you're getting any hint of the provider not being on board or not actually listening to you or promoting their own agenda, then you walk out. You have choices. You know, the doctor isn't always right. And there are a lot of providers now who are specialists in this area who will listen to you. I mean, the odds are stacked against us. If you think about the word hysterectomy, it doesn't come from the Latin root mitra, like endometrium, myometrium. It comes from the word hysterical, right? So if we remove the womb, then maybe she won't be as hysterical. So if you want to talk about inherent provider bias, and it's not just male providers like the patient just alluded to, it's female providers as well. And so, you know, I've worked with a company called Peanut where we have reworked on harmful medical language. So you don't use words, things like incompetent cervix. We've worked on better representation of minority women so that doctors are better equipped to understand and talk to patients about these issues. And so first and foremost, I tell patients they have a choice. They need to get as much education as they can about their own body and their own conditions and seek out the best providers who will listen to them and who will partner with their care. How I'm combating this amongst other providers is education and working on those types of projects. So like I mentioned, research. Data is the only way we're going to narrow that gap. Education. So we constantly educate our patients. We give them a safe space to ask questions. If you dismiss someone, they may never open up again, and you have made that patient invisible forever, because you can't imagine the amount of courage it finally took to maybe address her sexual pain or her fears about her infertility. And if you blew her off. And the third thing I would say is often keeping up with the latest, greatest medical innovations and technology. I will tell you in this space, and I firmly believe it's a race issue because it disproportionately affects minority women, that even less dollars have been placed on fibroid research. And so when new technologies come out, I'm so excited because it's been so long since we've seen innovation in this space. But seek out the providers who know about all of the options and who are willing to offer them to you. I hear it day after day. Well, they told me hysterectomy was my only choice. I'm like, did they talk to you about the medications? Did they talk to you about the injections? Did they talk to you about radiofrequency treatments? Did they talk to you about uterus sparing options? And they said, no, they just told me hysterectomy was my only option. And so sometimes it's the provider themselves do not know, or they don't have access to the latest treatments. So those are my pieces of advice on ensuring that you are not dismissed and that you are visible in your own care.
You branched out and created HerMD. Is that specifically because you saw that there was this disparity and that you needed to really laser focus on women and providing the healthcare that maybe you didn't see in the general kind of pop?
Yeah, when I was in a very traditional practice, I'd also tried, being a professor, and I was struggling because women were coming to me post-cancer, with complicated issues, whether it was infertility, menopause, sexual health. And, I'm given 15 minutes and practicing doorknob medicine or what I call drive-through medicine. And at the end of the day, I couldn't remember who I saw, whether or not I had made a difference. And when you spend, nearly 2 decades educating yourself to make this difference, and I nearly lost my mother when she was 45 years old because of dismissals at the hands of her healthcare providers. So I had really gone into medical school with the intention to make a difference for women. And when you feel like you're in the middle of your career, I was almost 40 years old and felt like I was making no difference. And I went to multiple hospitals and I had a business plan about how we can spend more time with patients and we don't have to be prisoners to the insurance system. And we do take insurance at HerMD, but there are other ways to make those appointment times longer. No one would listen. And I went to my father, like many of us do. And I said, what do I do? And he said, if you can't find an open door, he's like, build your own door. Mm-hmm. And so that was what I did to solve some of the major problems that we are facing in healthcare right now. Because most physicians I know, they go in with the best intentions. You don't go to school for all those years to be dismissive. But when you're in a system that does not support you and does not allow you the time that you need to diagnose, to listen, and to take care of patients, a lot of them are helpless and very frustrated and very stuck like I was.
Thank you. I want to just shout out some of our friends who are joining us from Nairobi, Kenya, and from Alberta, Canada. So welcome in. We're so happy that you're here. If you have any questions, drop them in the chat. Ladies, I want to go to our patient advocates because I saw all of you like raising a hand saying yes, co-signing on everything that was said. Nikki, Nicole, Nikki, we have a Nicole and a Nikki, sorry.
Works. It works.
Nikki, let's do Nikki. Nikki, let's start with you because your hand was the first that I saw like co-signing exactly what was said. A lot of women just are intimidated when you get to the office. And so sometimes I say, write a list, write all your questions out before you get there, because sometimes your emotion, there you go. I mean, we're reporters, so
yes.
Clearly. Okay, go ahead, take the floor.
I'm like, ladies and gentlemen, okay, the reason I have the doctor I have is because number one, yes, the White Dress Project, but also I took a reporter's approach to getting the doctor that I wanted for myself. I went and found the other reporter that, well, in this case, a producer, Janelle's on here, a producer who had found a doctor in the area and she trusted that doctor. That's how I found my doctor. And it wasn't just, okay, so she's a nice person. No, I wanted to hear like some credentials, also bedside manner, because that's where I've frankly tossed a lot of physicians and said, I don't want to do this anymore. I have tips. So information is out there. All you have to do is ask. Also, start those awkward conversations. We're having one kind of right now, but what about your girlfriend groups? Not everybody has a perfect, white picket fence life. Start having those conversations, because the minute I started posting about not just my experience, but the work that is being done, everybody's coming to me like, I got a GYN. So I have to remind people, no, here are the doctors. I will happily get them to doctors, but if you start those awkward conversations, you can get those great results. Number 3 was bring your questions to the doctor's office. Again, I'm the daughter of a nurse, so she asks a million questions. So I was trained to ask a million questions. Bring the questions and then also take notes while you're in there. I know I look really dorky with my little my Steno notepad over here, but real talk, if you don't take the notes at that time and have them run it back if you don't remember a phrase or what does that mean, because I remember having a 2 long like legal pads of possible treatments, and that was at a doctor's office that I wasn't really feeling them, but they gave me information and I took that back to my mom. We started talking about it, and I took it to other friends who also had procedures done. If you take notes, you won't forget everything, because it's a lot to take in, ladies and gentlemen. And also, if needed, travel for your care. I hate to say it like this, but I've moved around a lot and I lost a lot of opportunities to have consistent care as I moved around. So I promised myself when I finally put some roots down somewhere that I'm going to have a whole Dora Milaje of doctors, okay? Like they're going to fight for my health and I'm going to make sure. And I'm not a sickly person. I just want to make sure I stay where I am. You have choices, people. You have choices in doctors. Hopefully you don't have to switch too often. You have choices in treatments. So I say, educate up. And no one said you had to be a doctor to understand this stuff. Everything that I have cut for the White Dress Project, real talk, is very easy to understand. And you have choices in your life plans. So you want a whole cadre. I mean, they get paid very well. So use the knowledge that you have right here. Those are my tips. I really was sitting there like, amen, because if you're not having those conversations, and I have been turned off by doctors who kind of, I saw the doctor once, and then I saw the nurse practitioners. And I remember one time where I was really in fire and pain because the big fibroid I had was crazy. And I couldn't get anybody on the phone, anybody on the my chart. Nobody was responding to me. And obviously I don't have that doctor anymore. So you have options, people.
Some people even have a hard time getting rid of their hairstylist. So I can imagine like getting rid of your doctor. That's a tough conversation to have. But Nicole, I want to go to you. Dr. Javaid had said, no one knows your body like you do. You live in that body every day. So what does it feel like? And many of the women here, I mean, you're preaching to the choir, but what does it feel like? Talk through the emotions of what it's like when a doctor really isn't hearing you.
It's really interesting because for me, I had lived with the fibroids for such a long time. It became me. It was my emotional, it was my physical, it was everything. And I almost felt like it was almost like my internal baby. It's kind of hard to kind of say. And it was really interesting because my doctor, when I became pregnant, I had no idea. I was showing my first 4 weeks, I was showing protruding out rapidly because of the estrogen in my body that was producing. And it was looking like I was in my second trimester. And here I was only 4 weeks. I was in the pandemic. I didn't know, I was thinking in my mind, oh, I'm just probably a lot further along in my journey of pregnancy, not knowing. So when I went in and I met the doctor, I had kind of moved into Florida. Here we are, pandemic. And it turns out he specializes not only as a GYN, but in fibroids. And so I can remember going through that whole stage and those feelings. I just wanted to hear the baby's heartbeat. And he sent me on another portion of the hospital to get an ultrasound, a more detailed ultrasound. And that at that moment here, this small fibroid became 18 centimeters. And I remember laying and I was like, okay, I see the baby's heartbeat. The baby was fine. And I remember hearing so quickly in my mind, he's probably going to ask me to terminate. I didn't have this discussion, but something in me that's like, I have a feeling the doctor. And I'm already calculating in my mind, what is going to be your choice, Nicole? Are you going to tell the doctor, I don't agree with you, I'm going to go on with the pregnancy? How are you going to advocate for yourself? And the next day I went to go talk to my doctor, and that was the question on the table. He said, you know what? I feel it would be best to terminate the pregnancy. Let's remove the fibroid because it's growing rapidly. We can't say how, where it's going to end. And I told him, no. I said, I want to go on. Whatever happens, happens, but I believe this is what's best for me. And the look on his face was like, oh, wow, I don't think I've ever had anyone to tell me no. And it was really interesting because my mother, she dealt with fibroids. She actually heavy bleeding. And I never actually saw her advocate for herself. She dealt with it. She just dealt with it. And here I had to make the choice to not only deal with it, but to advocate for what was best for myself and now my baby. So we're going to fast forward. I had the baby, turned out, the fibroid grew for 27 centimeters, but we had to wait 3 months after my having my baby via C-section to make a decision for a hysterectomy, which of course the doctor really wanted me to have, versus having an open myomectomy because it was so large. And I wasn't in the mental space, honestly, to have it a hysterectomy. And, you know, my mother was like, you need to have this hysterectomy, da, da, da. And my doctor was like, I think it's a great idea, but I really respected my doctor. He said, Nicole, I think you should go get a second opinion. So in my mind, I'm thinking, so do you not trust yourself? But I respected him more. And I seen another doctor and he said, you know what? Where the position or the biggest one is located, we think you can actually have this open myomectomy, but the choice is yours. And I sat into it and I was like thinking, I'm like, I'm not in as much pain as everyone kept putting on me. And trust me, when you saw me, it looked like I was carrying twins. I was very petite, but I was protruding. It was very big. And I remember sitting in my choice and I'm looking at my infant at the time. And I was like, I believe I can do this. I can believe I can do this. And I remember going through the whole cycle. I had been dealing with this, you know, the pain off and on, and we go in for surgery. And the doctor, mind you, we all agreed open myomectomy, no matter what. And as they have, like, the anesthesia is like it's about to kick in, the doctor said, but be prepared, Nicole, for a hysterectomy. And I'm thinking to myself, this is not what we agreed on. And I just start going lights out. I wake up the next, you know, after the whole surgery, thankfully was successful. And it wasn't a hysterectomy, it was an open myomectomy. And at that moment, I cried. It wasn't so much I had went through it. It almost felt like a death. I almost felt like I lost something that became so much a part of me, where now mentally and physically it's gone, and I'm happy it's gone, but now I have to come into the spaces, something that I grew with, something that I went through life with, pain with, now it's fully gone. And honestly, it was traumatic. It took me a moment. I don't know if it was, you know, part of the pregnancy or what, of the hormones, but I had kind of set into, here I've been doing research, here I have been trying to advocate for myself, all because of this fibroid that was growing and was really growing in my body. Now I kind of made it okay that I was living with it, because I didn't want to know what was on the other side, and not sure whatever treatment was out there, if it was going to be fully the right choice. But I really went on my gut. Here is a watermelon size of fibroid that you can see. And I'm like, am I going to live? Am I not? And what was really intriguing in all of this, I had a meeting with my doctor and he said, Nicole, I'm very proud of you for advocating for yourself. And I saw like the tears well up. He said, I've never seen anything like it in my whole entire career. He said, not only did you, go through the journey of this big fibroid and your pregnancy, he said, but there is something in the MRI that none of us actually seen. You actually had a big grapefruit size in your uterus that never showed up in the MRI. We don't even know how you were able to get pregnant. We don't know how you was able to hold the pregnancy. This is a miracle in itself. And and he said, I'm very proud of you for standing your ground. Of course I cried. I was like, oh my gosh, because you don't know. So I was very happy of my choice, even though I went through so much of pain and bad periods, because they tried to put me on codeine to suppress the pain, and they would send me home. It's like, this is before the pregnancy, I do apologize. They sent me home. They said, just deal with it. You're of age. We don't know, we don't want to tap into, especially in the state of California at the time I was living. And they had this big law where they didn't want to touch anybody that didn't have children for a myomectomy or for a hysterectomy. So for the state of California, they just want you to suppress and deal with it. And so I dealt with it for years. And honestly, I put it in the back of my mind. I lived with it. I just try to eat well. I try to function. And I realized as I got of age, this was not right. I need to find out what is the best solution, what is the best treatment and the best doctor to actually, for me to actually in my lifestyle to really advocate for me and give me the best options.
I want to jump in there if I can. I hate to cut you off, but I want to be able to get everything in our hour and 15 together. but you had said, it's not normal, right? It's not normal to live with the pain, but we tend to normalize it because so many doctors tell us to go ahead and just deal with it.
Right.
And Lana, you were dealing with it since you were 10 years old.
Yes.
But the hope is, and someone in the chat said you feel hopeless sometimes, but here's the hope, is that you never gave up on yourself. And so tell us about that continued fight and really how you remained hopeful, despite it all, because it can feel like you're in a silo and that, that this is just going to be your lot in life. So how do you turn that around? Speak to the folks who are listening, who are currently going through this and say, God, this is it. Like, I don't know. I'm going to have to just double up on pads forever. Like, I don't know what to do. Give us a little hope.
Yeah, so I know what it's like to feel like there's no hope. I was at a point in my 20s where I was ready to commit suicide. I was having bad periods since the age of 10, bleeding all over myself, not understanding what's going on with my body, being, improperly diagnosed over and over and over again, going to the emergency room and they're just saying, it's just a cyst on your ovary, go home, here's some ibuprofen. And I was popping ibuprofens like Skittles because I was in so much pain. And it was really, really hard. And like I said, I remember looking at the knives ready to cut my throat. And that was the lowest point in my life. But over the journey, as my husband said, you know what, I love you with or without children. It gave me strength. And God said, you have a purpose. My middle name is Hope. I never knew what hope meant until that moment. So now, yes, after 8 years of infertility and multiple surgeries, I was able to give birth to my first child in 2013. Then, secondary infertility hit. And like Nicole was saying, like I had an open, not an open myomectomy, but a robotic laparoscopic myomectomy in February 2021 to remove 3 fibroids that I carried around for years because I was told not to worry about it. Let it just stay in your womb. It's fine. Why would we carry around fibroids? If there's something stale in our refrigerator, we get rid of it. We don't just let it stay in there. But for us, we just carry it around. It's okay. We can just go about our day. Let's go to work. Let's go to school. It's all right. We keep smiling through the pain, but we shouldn't do that. We have to speak up for ourselves. And I remember right before I had the myomectomy in February, they said that there was a cyst growing on my left ovary. And I said, no, I don't agree with that. I need a second opinion. And that was that strength. I didn't have that in my 20s, but I gained it in my 30s. And I went to get an MRI, and that's where those 3 fibroids were growing. And like I said, I had the surgery in February 2021, got pregnant in August of 2021 with our second miracle and gave birth 4 months ago through via C-section. So don't give up. I am a witness that you should advocate for yourself. Now, even if you don't get pregnant, throughout the process of getting your fibroids removed, you are still worthy. You are still enough. There's still purpose in you. So I'm using every opportunity to share my story because it's not over. Don't give up on yourself. I'm still here. I'm still standing, and we all are still standing throughout the process.
Amen. Thank you for that word, Sister Leanna. That was great. And who knew your middle name was Hope? Congratulations, girl. You look fabulous for just having a baby 4 months ago. I think I was probably still in sweats and no makeup and head wrap and all that stuff. Dr. Bradley, I want to go to you. Before I go to you though, someone in the chat had said, when you Google up fibroids, the definition says, well, they're basically harmless, right? And one woman said I fume when I read that. And Dr. Javaid, you said it goes to your point where we need to change the terminology that is holding us back and that is preventing maybe the additional research or seriousness. So Dr. Bradley, talk about just that partnership with the patient and how valuable that is in really building that teamwork to make sure that their individual case, like you said, fibroids are different for everyone, that their case has the best outcome.
Thank you. Well, one thing I'd like to say, I do believe that words matter, as has been mentioned. And I really want on my epitaph to say she stamped out the word tumor. I really do not like healthcare professions, literature, what's in the newspapers, articles, to use the word tumor, because when we as women think of tumor, we think of a breast tumor, a cancer, something malignant. So I do have to normalize some things. I mean, if I had $1 for every person that asked me why do women get fibroids, and it is from what you eat, from lack of exercise, too much exercise. One patient told me she's having too much sex. That's why her fibroids were growing. I said, well, I keep doing it, then let them grow. You know, I'm just joking, but we don't know what causes fibroids. But I really want to just make sure, because that we do not promote medicines. And this is a concern I have about some of the new medications, which are very therapeutic, or surgery, whether it's robotic, laparoscopic, open, or hysteroscopic. You would never find a gynecologist in their practice to see patients if we treated all fibroids, because literally everybody has them. So we do have to normalize them. We don't know what causes them. Yes, they can cause a lot of discomfort and quality of life issues, but I also see patients who have had surgery, hysterectomy, myomectomies. When you go back to ask them, why did they have it? And they says, well, I was told that I had fibroids or tumors. And then you go through the litany of the 15 different symptoms, and they had no symptoms. And what I say for my patients, again, I'm just one doctor out of many, but I do say, if they do not bother you, we should not bother them. Surgery is not without risk. I had 2 C-sections by the best doctor at the best hospital and had a significant complication. Things happen. Infection, bleeding, blood clots, okay, scars, different kinds of things that can happen. So I am a physician, I am a surgeon, and I do not believe that we should leave this conversation with the notion that because you have a fibroid, that it needs to be removed. You need to tell your story and to make sure that that story is heard. But if you don't have the bleeding issues, and you know, you can know what those are, the pain issues, the infertility issues, you know, maybe your complaint is that you look pregnant, and cosmetically that is disconcerting. I always say that most women are not going to die from fibroids. Okay, they can have a poor quality of life, and my job as their physician is to improve the quality of their life, but I cannot fix what's not broken. And, you know, again, 1,000 women die every year having surgeries. Okay. And I, anytime I open a body, go into a body, I know that that patient that's on the table should be there because nothing else worked or there were no other options. So I'm a little bit, I love surgery when it's needed, but it makes me really concerned when I see a complication, and it can just be from pneumonia to blood clots to keloid formation, to getting an infection. Again, there's a whole litany of things, even when everything is done right. So I just want women to know their bodies. If there are changes, sometimes the conversation is a tincture of time and watchful waiting. That is a treatment. And to be in contact with the physician, journaling, looking at all these different types of things, I think is important. But I really do not want to say that every woman with a growth needs it out. And so that's, I just want to kind of equalize that, if that makes any sense. And that is, as a surgeon, gynecologist, that's my humble opinion. And I do think that we operate or offer procedures on too many women without any symptoms. That's just how I think. And we don't know what causes it, and I don't have the crystal ball, you know, depending on your age. If you're in your late 40s, it's less likely, less doesn't mean zero, but less likely to have new fibroids to grow. If you have a myomectomy, get pregnant, you're less likely to have another recurrence. You see what I'm saying? So there are many different reasons, and patients will say, you know, is it going to continue to grow? I just say, I'm on the path with you, let's follow, because I don't have the crystal ball.
Bradley, thank you so much. That was right on time. We had just, a question had just popped in from Naya, who said, I have small fibroids they haven't bothered me or caused me any pain. What action should I take? So I hope you took down some notes, Naya, because the doctor really gave some great advice there. Another question, does either Dr. Bradley or Dr. Javaid have any recommendations for GYNs in Florida? I'd love to consult with them, but they are too far away. Don't know if you have anyone you can put in the chat. Go ahead real quick.
Let me just say something. Don't forget, because of COVID, at least our hospital at the Cleveland Clinic, we do a lot of intakes virtual visits. I do virtual visits on a Monday from my home. We can get your records scanned in, your ultrasounds, your MRIs, your labs, and we can just talk. Of course, it does not include an exam. I am going to promote, I am medical director of the AAGL, American Association of Gynecologic Laparoscopists, an 8,000 member international and national GYN society, where the physicians who come to the meeting are really highly skilled physicians, top of their game. I would advise that you look at the AAGL website, and we have it for patient portal where you can look for doctors in your area. Also this year, I'm very happy I'm partnering with the White Dress Project. We're going to be the first of its kind, but during our December meeting, which is going to be in Colorado, I'm having an hour and a half program with 4 physicians that are attending the meeting to look at all of the various methodologies for treating medically, surgically. And we were asking women in this group of White Dress Project, you'll be getting information. If I could look down at my cell phone, I can even ask you to keep your date on schedule because the person just confirmed with me. If I don't see it this very second, I will let you know, but it'll be a Zoom. It will be archived. And here it is, Saturday, December 3rd. Let's see, 11:30 to 12:30 Mountain Time, because we'll be in Colorado. So 1:30 to 2:30 Eastern Time. I'll share this information with the White Dress Project, but women can call in. We'll have 4 doctors, just brief presentations. People have asked us, can you show what the surgery looks like? What is, not just a sketch, we're gonna have robotic surgery, hysteroscopic surgery, 45 seconds, 90-second clips, ask questions through the chat. So do mark your calendar for December 3rd. We don't have the link right now. Eastern Time, it'll be 1:30 to 2:30. And more information to come, and we'll put that out. But I thought that this was a great opportunity. We usually have 2,000 physicians from all over the country. I used to be president of that association, and now I'm the medical director, which means a lot of different things. But I thought it's important that the specialists, the minimally invasive GYN surgeons, where we meet. This has been going on for almost more than 50 years. We just had our birthday, and really great physicians. So you can go to AAGL, look it up, and find doctors in your region. And sometimes you can do, even from a different state, a virtual visit. At least our hospital offers it. We as doctors don't know everybody in every city or state or insurance. Everybody takes different insurances and things like that, but it's a good way to get started.
Dr. Bradley, I do think that is one of the benefits of the pandemic, is that our access to each other, where in various parts of the country, we had someone from Kenya, someone from Canada, you can get these doctors to literally step into your living room and answer your questions. And that is an invaluable service. So we did learn something, and there were some benefits from the pandemic. But Dr. Javaid, talk about, so I want to just circle back to the focus of our forum today, which is implicit bias and the history of inequities in this country when we're dealing with generational pain. Parents, moms, aunts, grandmothers who have just kind of waited for menopause to be relieved of their symptoms. How do you encourage professionals, doctors, to try to change that conversation? And what do you recommend that patients do in regards to changing that conversation and now flipping it and saying, we're gonna kind of take control of this and really try to not erase history, but try to create our new future?
So providers and patients need to recognize just because it's always been that way doesn't mean it has to stay that way. And so opening doors of conversation with family members, with friends, with providers, really telling them that the agenda isn't always to get the history, exam, medication, diagnosis all done in a 15-minute visit. So if my peers that I'm teaching are in an institution that only allows 15 or 20-minute visits, I tell them to segment it out and maybe use the first visit to really get the history and really listen to the patient and just spread it out over a couple of visits. I know that's not as convenient for the patient, but if that's the system that they're working within and they really want to treat the patient, then that's a way to eliminate that time bias, that disparity that we have. I encourage physicians to get involved in, the renaming revolution like I was involved in. We created a glossary of care and new terminology that was meant to be provider facing. We don't get sensitivity training. And so it's a great tool for providers to have, but it's also a great tool for patients to have because it gives them words and terminology and places to start talking to their physicians about. And I think organizations like this, I will tell you, I'm married to a physician. He's a hematologist, so and an oncologist who takes care of a lot of fibroid patients because he deals with the anemia that comes from it. And he said until he went to the event in DC, he would always tell his patients, oh my God, I'm so grateful it's not a uterine sarcoma or a cancer. This is good news. And after he listened to your stories and heard about, the infertility and the burden and the suicidality and the depression and some of the cultural biases that come with a woman not being able to have a baby and a man walking out the door. I remember being in DC in that room and crying, listening to that story, because I hear it all the time with menopause and sexual dysfunction. I had not heard it in 20 years of dealing with fibroid patients, and it really opened both of our eyes. And so as providers, we are teachers. But if you're not learning every single day from your patients, then you're not doing your job well. And so you really have to be open to learning as much from your patient as you are teaching. And so that's how I tell both the patients and providers to navigate this.
And
I love that.
If I could say just one thing, not all doctors are alike. And I don't know if this is politically correct, but especially for OB-GYNs, I think personally, when you need surgery, you should be seeing a doctor who's really committed to gynecology only, or the majority of their practice. Most obstetricians spend 80% of their time with delivering babies, which is important. But I think a surgeon that's operating 2 or 3 days a week, constantly, I did 6 surgeries yesterday on Monday. We have 2 full OR days. Sometimes I'm operating 10 to 12 patients a week. My hands know what to do. Our hands know what to do. There's no surprises. So I also, because I'm, again, for transparency, I'm medical director, former president of the AAGL. We are the society that said, let's look when possible, not every case, because there are cases that need to still be open, but when possible, look at minimally invasive surgery or MIGS, MIGS trained physicians. I'm also a part of, we have 60 fellowships where we train young physicians in a gynecologic spectrum of fibroids, bleeding, and things like this. When it is possible, you should find a physician that is fellowship trained in minimally invasive GYN surgery, some wide MIGS or small surgeries, smaller incisions. You go home the same day. Some of the patients who have surgeries become addicted from their first female surgeries to narcotics. So we have what's called an ERAS system, early recovery for early eating, ambulation, less need for pain, smaller incisions, and the work is done. It is not saying that we never open a patient, but I really do think that women who are planning surgery should find a fellowship trained or a physician that has spent a lot of years with doing surgery and not diluting it with obstetrics. And finally, I think going into surgery, you're healthiest, the best blood count, correction of your anemia. And there's many medicines, IV iron. We're not trying to push getting blood transfusions. If you're a smoker, to stop smoking. If you're diabetic, to get your hemoglobin A1C under control, to be at your best for surgery, knowing that the surgery, when I say elective, it's not like getting a facelift or tummy tuck, but elective meaning it's not an emergency that brings you to that space. So I would ask the physicians how many cases you do a week, a month. Okay, how many days a month do you do surgery? Do you have a team? Because every fibroid is so different. You know, every person, I don't do robotic surgery, but I know who needs it. I don't do certain kinds of things, but we know who can get that. And having that team is so, so important. You know, here at the Cleveland Clinic, we're #1 for 28 years in heart and vascular. When my dad needed heart surgery, you know, we went to one doctor that did 10,000 of these procedures. There's something I've done that I've done 14,000 of in my career here. So what I'm saying is we're not all the same. I probably would be shot down saying this to a group of doctors who think that they are the same as everybody, but they're not. And you need to find that. And looking at, someone mentioned their training, what they do, how many they do, and who, if they don't do it, who could they refer you to? Because that's the doctor that you will want to see. And that's my humble opinion.
And if your doctor is offended by you asking how many cases you've done, then you're going to the wrong person. So those of us who are really comfortable and really good at what we do, we're very transparent about our experience level, how many years we've done it, how many cases we've done. And we also know our limitations. I don't do hysterectomies either anymore because there are much better people to do them robotically who've had that fellowship training. And so I think those providers are the ones that you want to align with. And I chuckle sometimes with women, you know, I talk to them a lot of stuff. Sometimes they're choosier about their hairdresser or their manicurist and read more reviews, thank you, than they do their own doctors, which just cracks me up because I'm like, well, how did you get to that doctor that was so horrible to you? Well, I just opened up the United Healthcare thing and I looked up who is in network and I'm like, okay.
That's what you got. We appreciate both of you being so honest and transparent, and the ladies in the chat are praising your honesty. We are at 1:03. I want to wrap this up, but before I do, there are some questions in the chat that I want to get to real quickly, and then I'll give our esteemed panel about 30 seconds or so to offer some final thoughts. So Jania has a question. I have over 20 fibroids, too many for doctors to count. I'm preparing to have a fibroid removal surgery by the end of the year. I'm exploring options to freeze my eggs prior to the procedure. Are there any major risks or concerns with egg freezing before a fibroid removal surgery that she should be aware of?
I am not an infertility physician, but sometimes when you look at the anatomy, getting your eggs, well, if the uterus is normally the size of a lemon and you have 20 fibroids, your uterus could be the size of an orange, could be the size of a pineapple, could be the size of a basketball. And right next to it are your tubes and ovaries. So if the anatomy is distorted, meaning the ovaries are far away from the uterus, or they're hidden, so to speak, it may be difficult. You should really talk with the fertility physician because they usually do a transvaginal ultrasound, and sometimes the anatomy is very distorted so that it cannot be done, meaning the retrieval of the eggs before surgery. And also look at your age. The closer you, and again, we've heard miracles on here. I'm looking at a picture of a woman that I took out 70 fibroids and she was 47. She was able to get eggs from another woman, but her partner's sperm. She had twins and she carried, delivered, breastfed, experienced pregnancy, but we kept her uterus. Another patient's picture I'm looking at took out 26 fibroids. And these are, quote, I hate the word, like we're talking elderly pregnant women. What do they call elderly nulliparous patients? But we can help, saving the uterus. That's the home for the babies. It may not be their eggs, but it could be their partners. We just had a friend of mine, I just went to I was at University of Cincinnati. We had a reunion. Somebody 53 took another woman's eggs. Her partner could not, the sperm count wasn't correct, but different egg, different sperm. She just had twins. She's 53. So the uterus was there. The little boys are 3 years old now. She's 56. So you really need to talk with your fertility physician. Don't wait too late. I don't know how old you are, but sort of put all of that together and see what's possible and how many eggs that they can do.
There's definitely more risk when the anatomy is different for any reason. So you have to worry about increased pain, blood loss, and just the procedure being more difficult. So definitely have that consult with an REI, which is a GYN that's done another 3 years dedicated in a fellowship in reproductive endocrinology and fertility. So they have that advanced training and experience.
Wonderful. Wonderful advice. Thank you so much. There is hope, and there are resources. There are doctors like Dr. Bradley and Dr. Javaid who will listen to patients who know that they don't have all the answers, but will work in teamwork and in collaboration with you so you can get the best care that you deserve. I want to close us out with just 30 seconds from our wonderful panel. First, a round of applause for just a really robust, outstanding discussion. It is inspiring each and every time that we do these. And there's power in community. And that really is the magic of the White Dress Project. And thank God for the world of Zoom, so we can all get together and share our thoughts and encourage each other. So with that, I want some more encouragement. So I'm going to go to Lana for your 30 seconds, and then we'll go around the room.
Yes, I'm just so appreciative of this conversation to the White Dress Project. And I just want to say that you're not alone. I felt many a year that I was alone on this journey. I was the only one going through this, dealing with infertility and fibroids and other reproductive health issues, but we are not alone. This is sisterhood. We must tell each other our stories. We must talk to our family members. Mom, you said you had problems with bleeding when you were younger. Why did you have those problems? We need to talk to each other in our community. Sometimes we don't, and we need to stop that. We need to break that cycle. So, continue to advocate for yourself, continue to speak up for yourself, and continue to love on yourself. Through the journey, I remember I did not love myself. Now I do. Through the journey, love yourself and know that you are enough just as you are.
Back on that is definitely advocate and love. I'm a firm believer of loving. One thing about this, during the whole journey, and that's my whole mantra, is enjoy the journey, is speaking life over your body, speaking life over yourself. Yes, you're not alone. Find that community, connect with it. Doesn't mean that you're trying to have a down day. It's actually making sure that we're all connected, making sure that we're all flowing together. And honestly, there's so much power in community. There's so much power in love. There's so much power of knowing that you are powerful, that as you are advocating for yourself and walking your journey, that there is definitely a light as you're walking your path. So just remember, keep walking, keep knowing that you are powerful, and keep loving yourselves.
Final words is, this is not the time to cut corners. This is your health. You get one body. So you don't want to play games with that idea. You want to spend money, and I don't want to say go broke, but think about it this way. I've had to talk too many mothers into taking care of themselves. They want to hold that money for when the kid has an event, but you have identified that you have something going on with yourself. So if anything, spend the money on your family indirectly, but you do need to take care of your health first, because you can't take care of anyone else if you can't take care of yourself. And please consider traveling for better care. I wrote in the chat that I have recovered the remote area medical clinics at least twice in my career. And I've seen how there is limited access to healthcare in many areas. And it seems like for a lot of people that are chiming in, you probably have access to it. So if you would pay to go to Tulum, you would pay to go to Caraco or wherever you want to go, then maybe you should consider making a trip out of getting your uterus taken care of. Good luck.
Thank you, Nikki. Dr. Bradley.
Thank you so much. Two things. I do want to just say one thing before the 30 seconds. The thing I am seeing right now, and this is for those of you on the call with mothers or grandmothers who had fibroids or getting older and having fibroids, I've diagnosed endometrial uterine cancer a lot in the last month. And all of the women in their 60s, 70s, or 80s, and they come in, the chief complaint on my sheet for the day is, I'm having bleeding from my fibroids. That's what it says. And once you go through menopause, the fibroids are still there. They're smaller, they're asleep, they're dormant, they're hibernating, but the other tissue inside is the endometrium. That's a whole different thing. It's different from the fibroids. So women on this call who know women that are now in their 60s, 70s, even 50s who've stopped their periods, women will say, oh, but my bleeding, just last night I did this surgery. Oh, that bleeding was just so little compared to what they suffered with for, a century, 20 years, 10 years. So when it started back up, they thought, oh, it's not that bad. Please, please, once your periods stop, they should never restart. It doesn't mean cancer, but to think of something else, see a doctor. And lastly, my favorite poet, Maya Angelou, says, when you know better, you do better. And so on this panel today, you've learned a lot. You've got to know a lot of new information or learn a lot of new information. So let's do better for ourselves, our family, and obviously our community. And that's what I would say in parting.
Thank you, Dr. Bradley and Dr. Javaid.
So we alluded to what we learned in COVID and expanding healthcare. So HerMD is at the end of the year going to be in 15 states, telehealth by next year in all 50. And we will have 7 locations open by next summer. So we're expanding all around the country. So we'd love to take care of you and discuss options and make sure you get to the right specialist. As I mentioned, we were founded on the foundations of empowerment, education, and advocacy. So all of our educational events are free. So follow us on social media. You'll see us on TikTok. You'll see us on Instagram. You'll see us on Facebook. Oftentimes I'm talking about fibroid treatments. We're taking questions from patients. It's a great way to get access to some great information to help empower you with your next visit. And then the other thing I would say is, there's a book that I love. It's called Half the Sky. We alluded to in telling women to take care of themselves, and then their families will be taken care of. And so it's based on an ancient Chinese proverb about women holding up half the sky and how families and children do so much better when women are actually empowered and can take care of themselves. I would check it out. It's called Half the Sky.
Thank you so much. And I would just say we all have to give ourselves a bit of grace as we embark upon this journey of empowering ourselves. It takes work. Sometimes it doesn't come naturally for us, but hopefully with this conversation, you were able to be inspired, to get some education, to be informed. And we wanted to empower you, and we hope that you will fight for the best care that you deserve, and know that you are not alone and you don't have to suffer in silence. You have a community and some people in high places, including Dr. Javaid and Dr. Bradley and all our wonderful patient advocates. Thank you so much for joining us. This has been our first webinar, first of 2. For the White Dress Project in collaboration with Healthy Women, and the second is September 7th. So keep that on your radar. Keep following the White Dress Project on social media, and take care of yourselves.